And so that is its own entity. And we still don't understand the pathogenesis, and we're not 100% sure that those cells are technically podocytes. They're in the right location, and they resemble those cells, but it might be that they're a dedifferentiated form and are like pre-podocytes. So again, all that's molecular, all that's research-based, although there are definitive classic cases in humans that cause collapsing variant of FSGS. And it's very important for the MD nephropathologist to recognize that lesion, because those patients progress to end-stage renal disease much more quickly than patients that have typical FSGS from just regular podocytes. And the two cats that we've had that have had the collapsing variant, that we said it resembles a collapsing variant. One of them, we got a necropsy sample, so we don't know how it would have progressed. And the other one is from UC Davis, and I haven't gotten feedback to figure out if the cat is doing better. Both of them were young cats, though. So that might be something that we'll investigate in the future. But we have not seen a collapsing variant in dogs. I have seen podocyte mitotic figures in a single dog once, and it was one single mitotic figure ever. Okay, NC State had a quick question. Did you want to repeat that, because I can't see the chat?
No, but it's more questions about some subtle densities near the glomerular basement membrane that might be immune deposits, and I mean things like this. And again, once you appreciate that the consolidation or condensation of actin filaments in the podocytes that are rearranging their cytostructure can end up making somewhat electron-dense regions. That explains most everything that even comes close to being a suggestion that might be misinterpreted as an immune deposit in this image, I think.
And from a diagnostic standpoint, remember that I'm the one scoping them, and I can go to really high mag and look at them very closely. And if it's from a board standpoint, I think it would be very unfair for an exam committee to give you an EM without also giving you the associated immunofluorescence image. So from a board standpoint, they would give you a classic, membranous and a classic very granular IF photo. But from a diagnostic standpoint, I get 50 images. Well, I don't take 50 images, but I look at a whole bunch of different capillary loops, and I take representative pictures from like 10 to 12 of them. So from a diagnostic standpoint, I can go and make sure and verify that that those are active filament condensation versus immune deposits. So don't get too worried about this kind of thing and figuring this out on boards, because it wouldn't be a fair question on boards if they didn't give you an IF. And plus, it would mean that now you have to interpret multiple things, and that's why boards would like it. So. Okay, so I think we can go to the PowerPoint unless there's any other questions about this panel. NC State, did we answer your question? I don't know if you can type. I don't know if I can see the chat. Thank you. Thank you, NC State. Okay, so this dog, I gave you a hint to Google, and that's just because I knew that our residents had seen this material before, so I didn't want other residents to be at a disadvantage. This case was a case, putting all this together with the global foot process effacement and with the very minimal changes via light microscopy, this case falls into the category of minimal change disease. And so this particular dog was on therapy for metastatic mast cell tumors. So she was on a tyrosine kinase inhibitor, and she'd been on it for about 5 weeks. Interestingly, the package insert tells you to check a UPC every 2 weeks just to check, because, and they say if you detect proteinuria, you should stop the drug. So the dog had normal baseline, had a normal 2-week evaluation, I think, or something like that. She had a normal UPC after being on the drug for a bit. Then at 5 weeks, she had a UPC of 20.8, so she spiked her UPC. And at the same time, she was hypoalbuminemic around 1.2, so that's severely hypoalbuminemic. The clinician astutely stopped the drug and then was tracking the dog. I think over the course of the next week, she became azotemic. So proteinuria was detected, I think, maybe 7 to 10 days before azotemia developed. The dog was hospitalized. She was being treated with multiple supportive care. They were getting ready to biopsy her. There have been previous publications about tyrosine kinase inhibitors causing minimal change disease in dogs. They contacted George to do a biopsy, but the dog quickly became anuric and had anuric renal failure, so they euthanized and immediately took samples post-euthanasia for processing by us. So the samples were of good quality, even though the dog, even though they're not technically biopsy samples. And so this case is a case of minimal change disease. It has a specific progression that we'll talk about on the next PowerPoint slide. But this PowerPoint slide is basically only talking about minimal change disease itself. Minimal change disease was named minimal change disease because there are minimal changes in the glomerulus via light microscopy. And it is a podocytopathy or maybe just podocyte injury or degeneration. But those podocytes are technically sublethally injured. They shouldn't detach. They shouldn't die. They're reversibly injured. And so if you do EM like we did, you see global foot process effacement, and that's about it. That's pretty much the linchpin for the diagnosis, is seeing global foot process effacement in a severely proteinuric patient. You should not see evidence of segmental glomerulosclerosis. If you see segmental glomerulosclerosis on the biopsy, the diagnosis is now focal segmental glomerulosclerosis. It's no longer minimal change. So if you think about it, minimal change disease should be on the reversible side of the spectrum, and you should have focal segmental glomerulosclerosis on the other side of the spectrum. It's possible that at one time you could get a biopsy and you would only see evidence of minimal change disease, but if that podocyte continues to be injured and eventually does die and detach, it could progress to focal segmental glomerulosclerosis. And then you biopsy them 2 months later, and now you see segmental glomerulosclerosis. Does everybody get that? Okay, I'm getting head shaking from OSU, so I'm assuming it makes sense. It's a minimal. Oh, sorry. Go back one more slide, George. So in humans, they either if they have evidence that the podocyte has been injured by an exogenous stimulus, maybe drug exposure or something like that, the first line of treatment is to get rid of the offending agent. And then in humans, they often give steroids. And that's an issue that I just want to mention. In humans, we give steroids for a lot of glomerular diseases. We tend not to suggest steroids in dogs because dogs are so incredibly sensitive to steroids and become or have symptomology of Cushing's disease. In humans, they do have a lot of anecdotal and folklore that steroids are protective for the podocyte, and so it might help the podocyte heal. We don't really have that type of background data in dogs. So a lot of times when you Google this disease and you look at all the human literature, you would think, oh, we'll just do what they do in human diseases, but we really don't believe in that same kind of philosophy of steroids being cytoprotective or podocyte protective. It might be, we just don't have enough data. Okay, next slide, George, sorry. So minimal change disease as a syndrome is the most common cause of proteinuria in children. It's usually young boys. They're maybe like 4 to 5 years old, and they become severely proteinuric. They don't really biopsy these dogs, these children. They don't biopsy these children. They usually start a course of corticosteroids, and the child resolves, the proteinuria resolves. And that's part of the background data of why we use steroids in humans for this disease process, because they just did it back in the 60s and the 70s, and they're like, hey, it works. We're not really sure why it works. It's probably protective of the podocyte. It's an infrequent cause of proteinuria in adult humans. There are many other diseases that would be on your differential list if you had a proteinuric adult, but it does happen. It's extremely rare in small animals. It's less than 10 cases in our biopsy service, and we have more than 1,000 biopsies in our service. In humans, it's usually associated with recent medication use. This is adult humans. That last bullet point should say adult humans. So NSAID therapy is associated with minimal change disease. Again, the theory being somehow the NSAIDs have injured the podocyte. And in that species, the published literature are TKI inhibitors or tyrosine kinase inhibitors. Sorry, that should be TKIs, not TKI inhibitors. Apologize. But anyway, so tyrosine kinase inhibitors. We have also seen one case on our service that we at least linked to D-penicillamine use in a dog that was being treated for copper storage nephropathy. So, there are probably other drugs that can insult the podocyte in veterinary. And we've had one cat recently that we could not find an offending drug at all. After multiple questions from the owner, they had no evidence of toxicity or drug exposure in one single cat. So that might have been spontaneous.
Of course, the cat didn't answer the question, so what exactly happened to the cat is unknown.
True. Okay, and so now this particular case is those tubular evacuation of the big protein cat. And with the progression of disease that we saw in this particular patient, it was minimal change disease that was associated with acute renal failure. So in humans, there is a minimal change disease with acute renal failure syndrome. So basically just add two different syndromes together and have an even longer disease name. And it's a so acute renal failure is a well-recognized sequela of minimal change disease in adult humans. Kids rarely become azotemic when they have minimal change disease. So adult humans with minimal change disease can have a late onset of acute renal failure, and usually they'll be proteinuric for a couple weeks, just like this dog was, and then progress to becoming azotemic. There are a lot of theories of how this would happen. Nothing has been completely identified as being the source of the acute renal failure in a subset of these patients. And so some of them think it's related with the therapy of using the diuretics in these severely proteinuric patients. Some of them think it's the proteinuria itself, that very heavy load of protein going through the tubules, and an abrupt onset might injure the tubules themselves. There is a recognition that endothelin-1 variants are associated with this progression to acute renal failure. So there's a lot of random molecular theories, none of which have been identified as being the only pathogenesis. But the syndrome is that you have acute onset of proteinuria and then you progress to azotemia. And you see acute tubular epithelial injury. And like George said, some of that evacuation could have been associated with the treatments that this particular dog was doing for supportive care. I think they gave the dog mannitol, and we often see evacuation with mannitol therapy. But this was really extensive throughout the course of the slide, and there was a lot of very dilated tubules and even those singly necrotic apoptotic cells. So this was more extensive than what we see with just regular mannitol therapy in this particular case. And the reason this is important is that human patients with this combo of minimal change disease and acute renal failure have a worse prognosis than if they presented with minimal change disease alone. They usually require dialysis, and it takes longer for them to recover. It's one of those things, I think, diagnostically, if you're looking at a biopsy from a patient and you see severe tubular injury and the patient is severely proteinuric, look at the glomeruli. If you can't find any disease in the glomeruli, then say, there are syndromes where you can have minimal changes in the glomeruli resulting in severe proteinuria, and that will progress to acute renal failure. We would need EM for all of this. So that's why I like my job, because I can suggest doing EM and then they do it. So Okay, so moving on because I'm kind of rambling at this point. Let's move to case 2. Sorry, George. And Jeremy, you ready to take this one?
Sure. Rachel, how's this for volume? Is that way too loud, or is that okay?
That's good for me. Is everybody else okay?
Sounds good.
Excellent. Okay, so in the H&E, what jumps out is segmentally the tuft is distorted by this aggregate of highly vacuolated, kind of variable size vacuoles within these cells. Who these cells are, I don't really know. And in some cases, nuclei appear nice and central, and in others, they're peripheralized by these vacuoles. Around the periphery of that aggregate, though, I think the capillary lumina are still open, and you can make them out, and they've got nice, nice thin walls. And then, of course, podocytes and the parietal epithelium are hypertrophied multifocally. And then at the kind of 12 o'clock position, there's some expansion kind of between the parietal epithelium and Bowman's capsule. There's sort of a zone of increased matrix that I'm not sure. I suppose we'll talk about that a little bit, but I think that was it for the H&E. Kind of very similar on the PAS. The vacuoles within those cells are for the most part PAS negative. There's a little bit of debris that's kind of weakly positive, but most of those vacuoles, so I don't think it's glycogen. And then you can make out again in that weird unusual zone at 12 o'clock that there's a little bit, it looks like kind of basement membrane, almost positive strands between the epithelium and Bowman's capsule. Okay. And then trichrome, kind of similar, kind of the vacuoles, there's no contents really staining up very well. There's a little bit of a collagenous, perhaps, matrix surrounding those cells within that aggregate. And then I thought it was interesting that in the tubules surrounding the glomeruli, there was quite a lot of uptake with the kind of red staining on the trichrome. I'm not sure what to do with that. I don't think it's muscle, but
Depends sometime on the actual trichrome stain how red the cytoplasm of the epithelial cells looks, and it may just be that this is a bit more red-ish example of the trichrome.
Okay. And then in the silver, it's kind of interesting that the cells do, the cellular contents in that aggregate do pick up some of the silver stain. It's kind of a heterogeneous sort of granular staining to it, and then some of the vacuolated areas might actually that are not picking up any stain may actually be the capillary lumina perhaps that are entrapped within this area. I don't know what you thought, or if they're cells that simply the contents are not staining, but I was curious how you would interpret that.
Some of them look like just holes in as opposed to, now this looks like it might pass for a capillary lumen entrapped in this, but I have a harder time with that one or that one, or a couple of these, but on a individual one after another basis, you get into some ifs, ands, and maybes that you can't really tell, I think.
But otherwise, smooth, regular contour.
Yep. So I mean, one feature of this is that this lobule that's clearly affected in an advanced way is adjacent in the same glomerulus to, for instance, this lobule, which by itself pretty much passes for normal in all of the images that we've looked at. So, okay.
Great. The EM. So there are, I can make out a couple of capillary lumina. The one has 2 erythrocytes in it. Around those, there are, as we've noted before, some fusion and kind of loss of podocytes. I thought all the way to the left they were a little closer to normal, but
you mean in here?
again, they're starting, yeah. But I think they're.
Well, you get a sense that they once were separated, but they're not
Right.
they're not normal, of course. But
and then down at the kind of that area, the bottom 30% of the image, we kind of have some cells where I can't quite make out cell borders, but the cytoplasm seems to contain some heterogeneous content. You've got a couple maybe membrane-bound vesicles or lysosome-like structures, perhaps, and then some have heterogeneous content, some very electron-dense material, and then others are kind of a little more homogeneous. But again, I wasn't sure. I suppose this is what was picking up some of that silver stain, is this heterogeneous content. But yeah, I think that's all I had about that. And the IF, we sort of have a kind of a global staining here, but it's not, it doesn't seem specific to any particular area. It doesn't match up with that aggregate, I didn't think. So I kind of thought this was perhaps more non-specific staining.
Yay!
Okay.
you got it right.
IF is the hardest thing to practice. So even if you have an IF panel, it could be that it's just a negative or non-specific panel. So, okay. So what's your diagnosis, Jeremy?
So I think this is segmental glomerular lipidosis.
And your comment in your previous report that you wrote to Dr. Baden?
So I dropped your name and said that previously you had said that you're thinking it's kind of a variant of focal segmental glomerulosclerosis.
Yeah. So, and I think we can move to the PowerPoint, and I think all of your points were, I think you did a really good description. I've had a previous question about what happens when you get a panel on boards that has 4 identical lesions all on special stains. And I honestly haven't been on the board's exam committee, so I don't know how they deal with it. If I were going to do it to save time, I would say the H&E, PAS, trichrome, and JMS stain all show blah, 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 like segmental effacement of a capillary loop by lipid-laden cells. And then I would say they are not PAS positive. You know what I mean? Like I wouldn't repeat myself over and over again for all the stains just to save time. I don't know if that's the way the board's committee would like it or not. And that's how my reports have been with you guys when I've sent you out the answers per se. I've basically said they all show the same thing, and this is what you specifically see on trichrome, and on the Jones thing you specifically see this. Okay, so that's an aside. Particularly with this case was a 1.5-year-old male golden retriever. He had persistent subclinical, which meant the dog did not have any clinical signs, but his UPC was persistently abnormal at 1.9. I did want to take this quick moment to mention the concept of nephrotic range proteinuria versus nephrotic proteinuria versus renal proteinuria. So nephrotic syndrome means you have at least you have multiple indications of nephrotic syndrome. You're proteinuric, hypoalbuminemic, you probably are hypercholesterolemic, and you might have some edema or ascites. You have multiple manifestations of the syndrome of nephrotic syndrome. If you have a UPC that is, well, it depends on where your cutoff is, but if it's greater than 3 definitively, even if you don't have the systemic manifestations of nephrotic syndrome, you can call that nephrotic range proteinuria. Sometimes people drop down that cutoff from 3 to 2.5. Some people even use 2, so it's not standardized. But basically, in human medicine, if it's greater than 3, they would say nephrotic range proteinuria, and they don't even care if the patient has ascites or has hypercholesterolemia. They just think that that proteinuria is nephrotic range. So that's my little aside about that concept of nephrotic range proteinuria versus nephrotic syndrome. The dog's creatinine was normal. It was 1.1. He was not hypoalbuminemic. He was mildly hypertensive. This owner, I think this dog is from Tufts, maybe, and the dog had had a positive Lyme serology, and their previous dog had had Lyme disease in the past, and so the owner was really conscientious about getting a biopsy early before everything started going bad for this dog. So they got a biopsy, and what we saw was the exact same lesion Jeremy just described, that affected many glomeruli. It wasn't just that single glomerulus. It was probably half the glomeruli had that segmental effacement by those foam cells, or those macrophages. So this diagnosis of lipid glomerulopathy or glomerular lipidosis, both of those are used synonymously, and it is a segmental lesion. That's one of the keys. It's segmental. They are lipid-laden. I wrote macrophages, although there is some evidence that they could be mesangial cells as well. So I probably will correct that before I send it out to you guys after this round. Sometimes it's easier just to say foam cells, then you're not committing yourself to a certain cell type. Glomerular lipidosis is listed in Jebb and Kennedy as an incidental lesion. That's totally incorrect, I think, in my opinion. In some of our cases, it is the only lesion we identify in dogs with proteinuria. Most of these dogs, when I went back and tried to look at them as a group, most of them are fairly young. And I don't know if those lipid-laden macrophages are causing the disease, or if the disease is somewhere else in the glomerulus and those lipid-laden cells are coming in to clean up debris. I don't know. I don't know the, yes, sorry, we have a question here from OSU.
So I assume that the statement incidental lesion comes from cases that had no fruit or no real item, you know, had
well, so if you look at the actual paperwork or the original papers that called it incidental, it's because these dogs weren't azotemic and they never reported a UPC. So if you see one glomerulus with this lesion and you're looking at a cross section from a necropsy case, whatever, you can ignore it. I won't be mad at you. If you have a biopsy and the dog is still alive and you see this lesion, then I would ask about a UPC. They probably shouldn't be doing a biopsy. They haven't done a UPC anyway. But to me, the reason that it was considered incidental is because they were using azotemia as their disease state, and they weren't looking at UPCs in these dogs. These papers are from like the 70s and 80s. And interestingly, like Jeremy was saying, it might be a variant of FSGS. We did a cluster analysis with cases that have immune complex disease, cases of amyloidosis, cases of focal segmental glomerulosclerosis, and these glomerular lipidoses all seem to cluster phenotypically with FSGS. And in fact, it actually closely represents this variant of FSGS in humans, which is called the cellular variant of FSGS. And I think the next slide has a picture of a case in humans. So not nearly as extensive as what we saw in our dogs, but this is lipid-laden cells inside the lumens of capillary loops in the cellular variant of FSGS. And again, this is a really kind of unknown pathogenesis in humans. They recognize it in that cluster of FSGS spectrum, but it's another one of those, hey, if you see it, this is what it is. I don't know how it got there. So whether or not our dogs have original podocyte injury that allow these capillaries to aneurysmally dilate, and now these foam cells are coming in secondarily, or vice versa. Maybe they have some weird kind of phenotype in their bone cells, and that's causing the glomerular capillary to dilate. I don't know which. But this is a human picture right here. This is from one of the publications of the different classification systems for focal segmental glomerulosclerosis. And I think we can round out with just other fun glomerular lipid abnormalities that are seen in dogs. These will not be sent out on the PowerPoint because they're being written up for publication, so I can't send them out yet. But this is actually a fun lesion that we've been seeing in a few dogs, all of which are miniature schnauzers. So it might be a breed-related thing. We've seen it in 4 dogs out of our 1,000 biopsies, all 4 of them miniature schnauzers. And so you see those really prominent, clear, open spaces. The first time I saw this, I thought it was a processing artifact, and I ignored it. Well, actually, I didn't ignore it. I did comment on it, because at one point I went back and Googled, or not Googled, I did a text search in our database, and I was able to find that case, but I didn't call it as a lesion. I just mentioned that there were these aneurysmally dilated capillary loops. So this is something. So the question here is, do these miniature schnauzers have hyperlipidemia? It's not as severe as some of the miniature schnauzers that we see. We actually have a geneticist at University of Minnesota who is helping characterize these miniature schnauzers, doing some gene sequencing for some of the APO alleles. So we're trying to figure out what the genetic abnormality is. They are hyperlipidemic, but they are not severely hyperlipidemic like we see in some of the really severe cases of miniature schnauzers. So anyway, so if you see a big, huge, open, clear space in the lumen of a capillary, check and see if it's a miniature schnauzer. And I think that I call them lipid emboli on the diagnosis. And I think the next one is the EM. And so do you see that kind of homogeneous, amorphous, semi-osmophilic material? This particular lipid embolus lesion looks somewhat similar to, now I'm forgetting the name, lipoprotein glomerulopathy in humans, which is a genetic disease in humans. I think so our lesions are similar, although the EM appearance in our dogs is a little bit different. In humans, it's a little denser, a little more electron dense than what we're seeing here in this particular image. Hopefully we'll have more information about this disease in the future. And I think I have one more set of pictures. So seeing cholesterol clefts in glomerular tufts should be very concerning. We've only seen it in one dog from our biopsy system. In humans, this is pathognomonic for atherombotic disease. So if you have a coronary cath procedure and you go into renal failure a couple of weeks later and they do a biopsy, I'm on the hunt looking for these cholesterol clefts. And even if I just see one, I have a diagnosis of atherombotic disease. Because they go all over the body and they're going to get trapped in those glomerular capillaries. They would also be trapped in pulmonary capillaries, but it's much easier to biopsy the kidney for me to look at. And they're in renal failure at the same time, so it's a good reason to biopsy the kidney. And that's what it looks like on EM. And this is hopefully going to be submitted this week. Michael Martinez is writing this case up. Yeah, this is the only case we've seen in a dog. And the dog had not had a cardiac cath procedure. He was severely hypercholesterolemic and was originally proteinuric and then became azotemic and eventually was euthanized. I think even before he got the EM back, he went into renal failure and didn't come out of it. Was not diabetic. And he was a Sheltie Shetland sheepdog, so we weren't sure about thyroid status.
Cool. Did the dog have coronary artery?
They didn't do a post, so we don't know. I mean, we're doing it a path in practice, so they didn't do a post.
Okay, but you assume that this probably isn't coronary artery origin, right? I mean, based on how that process is.
So there is, if you look at the actual biopsy, there are interlobular vessels that have more cholesterol emboli in them, or not cholesterol emboli, like atherosclerotic plaques in them. So even the renal vessels in one section of the biopsy.
Medium.
Huh?
Medium.
No, it's not typical for dogs. It's subintimal. And I mean it's there. So it's an interesting case. But so that's another. So you shouldn't have cholesterol clefts in your glomeruli. That is bad. Anybody else have questions?
Rachel, so if you find, obviously if they're biopsying the kidney because it's a proteinuria and you find focal segmental sclerosis or you find a segmental lipidosis, you've got an answer for them. They're already treating the dog. They just need to adjust what they're doing where they're sort of aware that there's already a glomerular problem. But what do you, suggest to people, like in the case that I had, where they removed the kidney for a separate problem? There was a hydronephrosis, there was a ureteritis. The glomerular issue, I think, was a well, not incidental anymore, is a very young dog, but is kind of a surprise finding. So do you have any advice or anything kind of prognostically? If you find it in one kidney, is it definitely affecting the other? Do you know kind of how it will progress so much at all?
Those are really good questions. I think Dr. Baden sent me the biopsy report just for that exact question about what do we do now. And my comment was that these dogs so once we get biopsies from, the biopsy was for the clinical indication of proteinuria. I told them that they should be tracking the UPC. I don't know if they had done one prior to surgery. I doubt it. And I said that they should start to institute protective therapy now. So already making sure that, if the dog is proteinuric, don't wait around and recheck. I don't know how well our standard therapies could intervene in this process as opposed to what it would be in a normal FSGS case. I don't know. But those are all those kinds of follow-up questions that we hope to answer with our service by being able to track the progression of those cases. But I couldn't immunosuppress for any of these. Like, you wouldn't immunosuppress for either of these two diseases we presented today. You would just be doing, optimizing your standard therapy of, ACE inhibition, controlling blood pressure, and maybe a low-protein diet. So it's a lot of wait and see. Does that help you?
Yep, thanks.
Okay, a couple things. One, the focal segmental glomerular sclerosis entity is really a pattern of injury within which, starting in people, there are lots of different subtypes, and it's not a single disease, but a pattern of injury in which there are a variety of different diseases. In veterinary medicine, particularly dogs with proteinuria, this pattern of injury turns out to crop up pretty frequently, and we are just in the beginning stages of figuring out the scope of different things that might cause it, and their treatments or potential reversibility and things. So I mean, we're better at recognizing it than we are explaining it, and I think that the thing we need to avoid trying to do right now is think that they're all the same, both in idiopathogenesis, prognosis, and treatment. And then my final comment, going back to the steroids that were mentioned before, there is a tendency in some circles to want to throw steroids at glomerular disease in dogs. My observation is that in comparative nephropathology, if one looks at human renal diseases, glomerular diseases that are highly steroid responsive, and none is perfect, but some forms of FSGS and certainly minimal change disease, particularly in children, response to steroids alone on the order of 80%. These kinds of things. My point is that the forms of glomerular disease that are highly steroid responsive in people are rarely encountered in dogs, and particularly with minimal change disease. Most everyone we've seen has been associated with a drug exposure idiopathogenesis rather than idiopathic. So I'm just momentarily, if you will, on my soapbox about the lack of a good rationale for throwing steroids at dog glomerular disease.
And we had one question here from OSU, and then in Glen. Would you predict that the lipid embolus and glomerulus could progress to that signal of things by themselves? So that's a very good question. I've had that exact question as well. So the question here was, could a glomerular lipid embolus, like the ones that we saw, just clear space, progress to the case that we actually had as a discussion with the foam cells? And I haven't seen any kind of progression within a stool biopsy core. I've often wondered that. How do you get rid of these lipid emboli? I don't know. But you would expect if it were something that is, he'd had one embolus, and then eventually there would be some foam cells coming and I've been eating it, and then the next one you would see a lipid embolus. I haven't seen that spectrum. Like I said, we've only seen these glomerular lipid abnormalities or these lipid emboli in 4 dogs total. So I don't know. So I guess to be continued. I'll post these descriptions and the PowerPoints with some of the images removed as PDF and send you all the link. I hope today it seems like we were really interactive. I appreciate the discussion. And I'll send an email maybe next week or next month if we want to do Ask a Renal Pathologist random questions and you guys want to send me snapshots. You guys can quiz me, I guess. Is that okay? Thank you, Jeremy.
Welcome. Thank you.